Good afternoon, friends. A warm welcome to this informal panel discussion on optimizing IL power calculations in various scenarios. I am Arup Chakrabarti, the lead instructor for this course. And helping me out today, we have Dr. Meena Chakrabarti, an eminent VR surgeon. We do a lot of phaco together. Dr. N. Sandhya, again a very high volume cataract surgeon with a lot of experience in IL power calculation, presentations, and teaching. Dr. J.S. Bhalla from Delhi. Again, he is a man of immense experience in this particular field. And Dr. Madhu Shekhar, who is in charge of the IOL department at Aravind Eye Hospital, Madurai, a very high volume center, high volume surgeon, and enormous experience in this particular field. So, in the past, cataract surgery's only goal was rehabilitation. So today we have converted into a refractive surgery. And the holy grail for us is plano 6.6 or whatever is the target refraction, achieve that. And this is a very, very happening field. It is the surgeon who has to be in charge of the whole exercise of IL power calculation. And there are a lot of articles, publications that are coming in the literature. Every major peer-reviewed journal will have multiple articles on IL power calculation. So it is a very happening field, and it is important for us to keep in touch as to what is happening. Any newer formulas have come up, any formulas have got a new upgrade, any new equipment has come up, any surgical refinement has come, any newer lenses which do better in terms of IL power prediction and information in this particular field. So where do we stand today? I always quote this particular study, Giacomo Savini from Italy. He presented his work on routine eyes, with not extremes. That is not a very long or short eye, or not a very steep or flat cornea. Using where the biometry was done using a swept source OCT based optical biometer, and his results were outstanding. 88 to 90% of the patients in this cohort were landing up within a prediction error of 0.5 diopters. So my question to the panel is, in your cataract surgery, day-to-day cataract surgery, do you audit your patients? How many patients meet up with your target refraction? What is the practice, Dr. Bhalla, in your place? Can you share the mic? So until unless we audit our results, we will not really know where exactly we are.
Exactly. When I was using older generation formulas, that time I realized my mean absolute error was much higher. But now I've gradually shifted to Barrett Universal 2, and although Kane also I have used.
So you have audited your data and found out that you're lagging behind the standard.
Yeah.
And then you have taken measures to improve those.
Yeah.
What about Dr. Madhu?
We are also auditing almost all cases because it is now EMR, electronic medical record. So we see our outcome, how is the outcome, and based on that, sometimes in one scenario like when we were using auto view, there was some plus spherical power, refractive surprises. So we have changed according to our audit one.
So basically, if you audit your patients postoperatively and found out that you have not met these standards for the routine eyes, you have a long way to go.
Yes.
And some of these points I'm going to cover. And another issue is, have we reached the limit? Many surgeons feel that we have reached the limit. We are doing very accurate measurement of the axial length. Keratometry is still a gray area in difficult situations. There are certain uncertainties. Discrete IL power steps, and there are manufacturing power tolerances. I'll come to it in the next slide. Effective lens position is again a Pandora's box. We really do not know where the lens is going to sit at a couple of months after surgery. And then it has also come to our notice that Nangle kappa and ocular biomechanics also play an important role. So perhaps many surgeons feel that we have reached the limit and there may not be a very significant improvements hereafter. So the problems is, there is a ISO standard for the labeling tolerance. So whatever power that is printed on the lens box actually may not be the same power. For low power intraocular lenses, less than 15 diopter, you can have a variation from minus 0.3 to plus 0.3 diopters. And for higher powers, the variation is more. So there is some kind of inaccuracy that will invariably crop up, and we have no definite say on these matter. And then these lenses come in steps of 0.5 diopter, and some of these lenses at extremes of power come in steps of 1 diopter. So again, we cannot choose the lens of our power selection because of the industry standard of making the lenses in terms of 0.5 diopter. Okay. Now, IL-POT calculation is something which transcends the preoperative period, intraoperative period, postoperative period. So in a cataract patient, for the question for the panelists, before you do the measurements, before you do the biometry, how do you prepare the eye for that? What all do you look for? And how do you prepare the eye before you embark on biometry for the patients? Madhu?
Like preoperative, it should be virgin cornea. Like when we are taking any, without any doing investigation, like sometimes we have seen that if we have done some investigation like duct or any contact method, then the corneal surface will become this tear film will get disturbed and will
So
get.
basically, we look for the presence of ocular surface disease.
Yes, sir.
And if the ocular surface is suboptimal, we'll postpone doing the biometry.
We will first treat that and
Yeah,
then.
we will treat the ocular surface.
Yes, sir.
And then maybe after 4 or 6 weeks, call the patient back
Yes.
and do the biometric measurements. And if they're reproducible, they can be accepted. Otherwise, the same treatment course have to be continued for a period of time. And as you correctly said, the biometry should be the nil touch technique on a virgin cornea. So not after gonioscopy, apprenticeship torometry, dilatation, and all those contact methods. No, they should not take place on the same day. That can definitely alter your measurements, the accuracy of the biometric values. Now, sometimes I have noticed in my own practice that when the pupil is small, whether I'm doing an ultrasound biometry immersion or doing optical biometry, if it is the pupil is small, I may not get the values and sometimes end up dilating the pupil. Do you think this is something that is a good habit? I mean, it improves your biometric accuracy? Dr. Balla?
I'm not too sure about that. If the size of the pupil is not giving you the axial length measurement, I would dilate. Otherwise, I'll try it 2-3 times to get a reading with the normal size, undilated pupil. Yeah. I'll try for that. In case I'm not able to, only then I'll subject to pupillary dilatation.
Basically, over the years, I've seen that if you dilate certain eyes, you can get a good reading. And so I have been doing it. And then this was a recent report with the ILMAS 700, which showed that for certain advanced cataract situations, about 9% of the patients, they do not have a proper good quality biometric value. So those cases, if they're dilated, almost 76% of those cases, you can take a good quality biometric value. So, it makes it more accurate. So this is actually a study published almost 3 years ago. And I believe that, it is quite useful, but it is not hard and fast. It is up to the surgeon. The problem with dilatation is, it alters the biometric parameters. This has been known for quite some. There are a lot of publications on that. So after dilatation, the central corneal thickness, anterior chamber depth, lens thickness, everything changes. So if you take these values into account and use them in the formulas, multivariable formulas, about in 25% of the cases, you end up with an IL power which is on the myopic side, 0.25, 0.5 or 1 diopter myopic. So I always tell my patients that when I'm doing a dilated biometry, that in 1/4 of the patient where this practice is followed, they should be on the target refraction you may end up choosing a lens which is 0.5 to 1 diopter more than what should have been chosen. So they may have a myopic outcome. So it is important for us to share this information with the patients, and because this is also borne out by the studies. As regards preoperative workup, Dr. Sandhya, when you are taking up a patient for cataract surgery, what are the devices that you use? What are the measurements that you do?
Sir, it is better to have axial length keratometry then anterior chamber depth, lens thickness, and preferably if you have more parameters, that is better. So if we can have wide to wide, and these things will add more information to our outcome. So we have access to optical biometry. So it measures all these things. We have access to LensStar and IOL Master 700. So optical biometers can measure all these things, and also we'll get keratometry information from that. So all these things we are calculating.
So basically, optical biometer can take care of all the requirements.
All the requirements.
Built in.
Yes.
And
Yes, sir.
in addition to if one is using a manual keratometer or auto keratometer, that is also okay.
That is also okay, and you can have an immersion ultrasound biometry if you don't have an optical biometry.
Exactly.
That is equally good.
Dr. Bharla, would you like to do anything topography or eye test for these patients? In addition to that, when would you do it? Would you do it routinely for all patients? Or?
No, not as a routine, sir. Only in patients with atypical corneas, in patients with keratoconus, or the patients who have undergone the previous keratorefractive surgeries, I will like to do. But normally, I will not subject these patients
you do
to
topography right test. Only when
No.
you're planning for contemplating a toric IOL,
Toric IOLs,
or a
yeah.
multifocal IOL,
Yeah.
or when you're working up a patient who has already undergone a keratorefractive surgery, so you
Yeah.
do these evaluations.
Exactly.
And we have to remember that contact lenses have to be removed, for a couple
Yes.
of weeks before the tests are
Yeah.
done. And again, this is the era of swept source OCD devices. We have different types of devices available. So any comments you would like to add on that? See, yeah, Madhu?
Yeah.
Who is using Argos here?
Yes, sir. Now we started doing a few months back, we got Argos. So penetration is much better in Argos. And that IOL Master 700 also gives good result. But a few of the advanced cataract or dense PSCC get rejected from that.
Yeah.
Then we have to do immersion and manual this one.
So I think it is important also, thank you for these comments, but it is important to remember that Argos gives a sum of segments.
Yes, sir.
On the other hand, the Iron Master 700, it gives a composite axial length. So the axial length which you measure with these devices are different. So when you use most of these current formulas, they'll give you an option that whether it is the biometry is done using an Argos or whether it is done using your Iron Master 700. And in fact, for the Barrett calculator universal 2, there's no such option. So if you're using Argos for biometry, I think, the Argos has already, the company has already modified the Barrett universal 2 calculator so that can be incorporated to give you more accurate information. So it is important to remember the values given by these two the biometric devices may not be the same because they work on different principles. And a particular formula, there are only 3 formulas in the literature which will allow you to directly take the Argos axial length, that is some of the segments. Now, if you have a optical biometer, is it an end of all your trouble that every reading that you get is reliable and you can go ahead with your IL power calculation, or there are certain precautions to be followed? Dr. Sandhya?
So calibration of the instrument is very important. So I'll check if as far as keratometry is concerned, if the K reading is less than 41 and if it is more than 47, we have to check. And if the axial length is less than 21.3.
So there is a series of parameters.
Parameters, yeah, we have to
these
calibrate.
machines have to be calibrated.
Yes, sir.
And there are the machines also have to be upgraded because there are formula upgrades. There are certain formulas which are already integrated with these machines. So those formulas have to be upgraded in case the formula writer has made certain changes in the formulas. Then A constant, for example, the IL constants, sometimes if a new lens comes in and or the IL constant has changed for a particular lens, a newer type of lens, so that also needs to be upgraded by the technician. So you have a list of the parameters which will which will indicate to the biometrist that the values, the scan that we have got is not correct, not accurate, so it has to be repeated. So just because you have an Iron Master or an optical biometer doesn't mean that it is the end of all your worries and you're getting accurate results. No. So there are certain precautions that have to be followed. Now you have all this exercise has been done to get very accurate, very precise biometric parameters. And now a question of using the formula. So Dr. Bhalla, what is your thought on the formula selection?
So Of the newer generation of formulas, I think Barrett Universal 2 is one formula which can be used for all grades of axial length, shorter axial length, average axial length, and even the longer axial length. But in extremes of axial length, let's say less than 23 millimeter or more than 26.5 millimeter, there they have found that Kane, EVO, VRF in the meta-analysis published, they score even better than Barrett Universal 2. And Hill RBF gives almost same reading as Barrett Universal 2. Although the premises of the both formulas are different, Hill RBF is mostly artificial intelligence based, but surprisingly they give results which are almost coinciding with each other.
Dr. Madhu, what about the older generation lenses, Holiday 1, SRKT, Hofford Q?
At present, we are using SRKT also. So that is also giving good result in our like normal range of axial lengths. But recently we have shifted mostly to Barrett's Universal 2 and we are getting good results with that.
Anything you wanted to say, Sandeep?
So I would prefer Barrett Universal 2 for all eyes, but slightly I'll be more inclining to longer axial length eyes. And if the axial length is short, I'll be choosing Kane formula rather than Barrett formula.
Okay.
But as a general rule, since Barrett Universal, it can be applied to all axial length eyes.
So I think by and large we agree that the older generation formulas are no longer serving us the purpose. We have moved on. About 10 years back, we moved on to Barrett Universal to Heal RBF. These are free formulas available on the respective websites. Then new kids on the block, Kane formula came. Dr. Bala mentioned EVO. Recently, we had the Pearl DGS and Hofford QST. In fact, there is a lot of new formulas coming in. This is a classification which I took from JCRS. 1 year back, it was published. And this looks intimidating, but it is a very, very methodical way of looking at a formula, classifying a formula. So the question is, now we have so many formulas, all right. Now, how do you use these formulas? You have the biometric values and you have your biometer. So how do you measure these, use these formulas?
So most
because
of
your
the-
machine may not have many of these formulas.
These formulas, they are available online, like Barrett, Hill, RBF, Kane, all these formulas are available online, free of cost. And also Barrett is available in the API-CRS and ASCRS website. And most of the optical biometers, they have incorporated these newer formulas, like Master has Barrett, Aegis, all formulas are there. Lenstar has Hill, RBF, Barrett, all these formulas are there. But only thing is, in the optical biometers, we have to upgrade these formulas, but in online formulas, they automatically get upgraded.
As soon as the formula
yes, sir.
changes, it is reflected in the formula.
Yes, sir.
Same thing what Madam told that it is now in this Master 700 or Lenstar or Argos, few of these newer generation formula are also upgraded.
These are all
incorporated in the, yes.
See, I feel in fact the last 7-8 years, I have gone to totally online IR calculation because the machine which I am using may not have all the formulas that we have, all the formulas which we have discussed, which are useful in certain situations. Plus, as Dr. Sandhya mentioned that these formulas may not have been upgraded. The IL constants might not have been upgraded. So why not go and do an online calculation? The only problem that remains is there is a transcription error, possibility of typing in, making an error when you're transferring the data. But then that has to be taken care of. So this is what I have been doing for almost all the formulas, and so it makes it much easier. Only problem is you have to have, if you take 4 or 5 new formulas, you have to take printouts and you have to compare. It becomes pretty cumbersome. So these are all the things available. And so as Barrett Universal 2, it is those of you who are not using it, it is free at the apscr.org website. And it gives the entire suite. All your IL power requirements will be taken care of by this particular Barrett suite. Very useful formula. And then Heal RBF also, we have been using it, and it has gone to version 3. It is available in the ASCRS website. So here you have Heal RBF calculator, and ASCRS website also, for your information, has added a lot of useful formula like Barrett Tori calculator, Barrett 2K Tori calculator, Barrett RX formula. So instead of going to the APSRS website, if you are the habit of following the ASCRS website, so you can do a lot of calculations without much hindrance. And so now this is a Hofford QST formula. So actually, I was having a discussion with Dr. Hoffer sometime back. So he says that Hoffer Q is an obsolete formula. He doesn't recommend the formula anymore, but people don't seem to give it up. So he has upgraded the formula with the help of two of his associates, and then has come up with the Hoffer QST formula. There it is artificial intelligence component is there. There are updated algorithms. So that also does it does a very accurate IL calculations of different requirements. Kane formula, it came about 7 or 8 years back. It does very accurate calculation both for non-toric cases, toric cases, keratoconus eyes. There is a keratoconus, component that has been added to this. In fact, the calculator also has the keratoconus, specific keratoconus that have been calculation that has been added to it. And Pearl DGS calculator, again, it is a very sophisticated calculator. It is free of cost, available free of cost because the gender can be integrated and is integrated into this. And it has the second eye enhancer. I'll come to it little while from now. But have you ever visited the IL calculator, the ESCRS site? So we have been using the ASCRS site, APACRS, their calculators. ESCRS site didn't have a calculator for till about 2 years back. 2 years back, they have loaded, they have an IL calculator which has been added to the website. And here, see, for example, this is the standard ESCRS calculator, and it has 7 modern formulas, Barrett Universal 2, UVO, HEAL RBF, Hoffer QST, Kane, Pearl DGS, Cook K6. So if you biometric parameters, if they're filled in these fields here, automatically this calculator will fetch data from all these 7 calculators and give you in a single printout. So it becomes very easy to interpret. Earlier on, I used to compare and contrast multiple sheets, and it was quite cumbersome. Sometimes it was quite bothersome also. So here, for example, ESCRS calculator has suggested a lens of 16.5 diopter, and this is suggested by Barrett, Cook, K6, HEAL RBF, then Kane, and Pearl DGS. So in one printout itself, one sheet itself, you see, the particular it gives a good idea as to which lens is to be selected and what is the level of agreement between the different formulas. So this does pretty well, and it has made our job much simpler. A toric component also has been added to this calculator, but it uses the Barrett toric calculator, EVO, Hoffer QST, and K. So these are the 4 formulas. So it has become very simple. I have calculated actually individually from these websites and from the ESL's website. The values are pretty much identical. So that has made a significant difference to my online calculation exercises that is done before a patient is taken up for a cataract surgery. I would like to ask the panel that when you use multiple formulas, Dr. Bala, like you just have one formula and you use the lens suggested by that formula, or you use multiple formulas in certain situations?
Sometimes when I feel that this formula is not giving reading which is expected, that time I will like to, or in eyes with atypical eyes, shorter axial length, longer axial length, or the atypical corneas, keratometry having too flat or too steep. There I like to use multiple formula, maybe more than 2, and then see whether the readings are agreeing with each other or not. So.
Nadu?
Same, sir. Like
Yeah.
in extreme soft eyes, or I want to ask, sir, in that shorter eyes, which formula you prefer? Like
we'll come to that. We'll have a talk.
okay.
We'll talk about shorter eyes. We'll
Uh-huh.
talk on the long eyes.
Yes, sir.
And we'll have a talk on post-vitrectomy situations.
Yes, sir.
And we'll have if time permits, we'll talk on post-refractive surgery, post-RK, keratoconus, those situations. Okay. So I always believe that when you have, as Dr. Bhalla mentioned, that when you have extremes of eye, it is always better to use multiple formulas. This patient was a patient with high myopia and had a post-ICL cataract, so cataract surgery had to be done. And I used, see, the axial length is always overestimated by ultrasonic biometry, optical biometry. So you need to use a Vankop formula, apply the correction factor to the axial length, and then use that particular axial length for the calculation. So this Vankop optimization option is different values are different from the 4 traditional formulas. Then they should not be used with the newer formula. This is only for the older generation formulas. SRKT, Holiday 1, Highgaze optimized axial length, and Hoffer Q. Okay. So I did all the 4 and found out that Barrett was suggesting a 2 diopter formula, but most of the 2 diopter lens. But all the other 4 formulas were suggesting indicating a plus 3 diopter lens. So I used a plus 3 diopter lens for this patient, and patient has done extremely well. So it is good idea to use multiple formulas and then arrive at a decision as to what is to be done. Next scenario will be, now you have done a cataract surgery, like this has been done, and patient has got a refractive surprise, and it's 3 diopters, 4 diopters. So Madhu, what will be your go-to approach?
For this, first we have to see that what is the cause of refractive surprise, what formula we have used, or any like decentration or effective lens position is changed in this patient.
So which is higher diopter than what should have been implanted has been
Yes,
implanted by mistake.
yes. Then
Okay.
we can
Wrong IL power.
then we have to calculate the IL power in pseudophakic mode, and that power what we get, then we have to, or that what we have calculated before, we have to check that whether why that means it gives means error in that. So we have to recalculate, and then in pseudophakic mode what we are getting, then we have to go for IOL exchange in this side.
Dr. Sandhya?
You can use the Barrett RX formula for this IOL exchange, and that will give the power of the IOL, means how much error has gone, and then you can replace with the new intraocular lens.
Dr. Balla, any additional comments? Yeah, see, now I would like to think about a piggyback lens for these patients, all right? Because, IOL exchange at times may be traumatic for the patient, and it may end up with artery segment trauma. So one of the options is a piggyback lens, and the power piggyback IOL calculation is quite simple. If your refractive target is plano, not plus or not myopia or hypermetropy, and post-op hypermetropy is plus 7 and minus 7 diopter, you can use this formula. You just, if the spherical equivalent was within plus 7 diopters, then you use spherical equivalent into 1.5, and whatever value you get, you implant that as a piggyback lens. And for the myopic surprise, you use a factor of 1.3. So this is more or less quite accurate, and then you can use the refractive variance formulas. These are given in Dr. Hill's website, the Barrett RX formula or RX formula. All this can be used for you to get what is the piggyback power, or if you want to exchange the lens, what would be the exchange power. So if you are using the refractive variance formulas, you don't have to measure the axial length. You just need to know what is the spherical equivalent, measure the K readings, and then the formula will give you what is the IOL power that is for exchange or for piggyback that is to be used. So that makes it very simple, for this thing. Now this is another scenario where you have operated on one eye, and second eye is still operated, and you would like to be wiser from the outcome of the operation in the first eye, refractive outcome, and before you choose the intraocular lens for the left eye. Do you have any method, any protocol that you follow for this? Sandhya or Dr. Madhu? Supposing if you are done on the right eye, a patient gets a minus 2 diopter, all right, and then now everything is correct. There is no wrong lens implanted. The lens is not getting decentered. It is well centered. There is interocular symmetry. Both eyes are symmetrical, sort of. So would you like to modify the power in the left eye? Yes.
So whatever residual we are getting, half of the power you can add for the other eye. Like if you are getting, if you put a 22 diopter lens, and then you are getting minus 2 refraction, and then if you are getting 20 diopter lens for the other eye, I will put a 21 diopter intraocular lens in the other eye.
That is one way of doing it. I think a more objective way of doing it would be, so there are a lot of studies that have been published. So what I would do is, when I'm using the Barrett Universal 2, I'll not take 50%, I'll take 30% of the refractive error. And then I'll set the target refraction for the fellow eye not at 0, but 30% of whatever was the refractive error that I got, and change the sign. For example, if I got minus 2.1 in the right eye, spherical error, okay. So left eye 30% is 7. So I'll put the target refraction as not 0, but 0 plus 0.7. And this has helped, this is actually agreed upon by many publications, and I have also been using it. So this is pretty well. So it is useful for us to wait for some time until the first eye operated eye has stabilized, and then you can use the value obtained in that eye to choose IL-PAR in the fellow eye. Of course, now the newer formulas, say there is a second eye enhancer. So this has been taken into account by the VGS calculator, and you can then use the first eye values and get an idea about the power in the left eye, in the fellow eye. Second eye to be operated. Now, this is a situation where patient had a PC lens, and you can see that lens has been kept in the sulcus. There is ovalization of the rexis and large PC lens. So the optic capture has happened, and then so would you, in this kind of scenario, would you like to use any particular power modifications? Dr. Madhu or Dr. Sandhya?
If the optic capture is done, then I will not change the power of the intraocular lens because the optic is sitting in the normal within the bag. So I will not change.
Dr. Madhu?
Yes, sir. Same thing. Like if it is optic captured means it will come to that position where that effective position we have calculated.
Yeah.
So if you are putting in sulcus,
You don't have to
then
change the power.
no
No,
need.
If it is in the sulcus, what will you do?
If it's in the sulcus, if it is in the sulcus, then we have to change the power, sir. Maybe by 0.5 to 0.75 diopter, I like to change, sir.
Yeah. So again, this is from Warren's website. So this actually gives an idea as to how the power adjustment has to be made. Roughly, it is a 5% rule of thumb. If you're keeping a lens in the sulcus, then power has to be increased by about 5%. But this is a formula which is very easy to remember, and this has to be kept in the mind when you have a PC lens with an optic capture, and when you talk about what IL calculation. This refers to the 3-piece lens. If it is the single piece, we are not talking about the power of the single piece lens in the bag. We are talking about power of the 3-piece lens in the bag, and then you modify it for the sulcus. So this is something sometimes we tend to forget.
Anything on that rule of 9, sir, based on power?
5%.
Like
Rule of 5%.
like 0 to 9 diopter, there will be no change. 9 to 18 diopter, 0.5 reduction, and 18 to 27, 1 diopter, and 27 and above, 1.5 diopter.
Yeah. That is also a good way of remembering it. Thank you. So another thing is, when you use a new lens, all right, and if you use the formulas, see, once the formula writers will tell you what was the biometric device that was used, what was the intraocular lens that was used. And sometimes, I was quite surprised when I saw that. These are the two lenses, one is from Alcon and one is from Johnson & Johnson. And the accuracy decreased significantly in long eyes for the Johnson & Johnson lenses. Okay, so basically, there are a lot of, I think, intraoperative issues that are involved. Your rexis has to be small, about 4.5 millimeters in size. And you have to ensure that, the back capsular contracture is uniform. But depending upon the lens configuration, the lens shape factor, etc., the lens shape, perhaps the position may change slightly and effective lens position may be different. So here, I think this is something which was a revelation to me when I went through that study. And I haven't experienced it, but this is important to keep in the mind that when you're doing extension of the eye, a lens which you have not been accustomed to, there may be some, variations in the we're dealing with a very long axial length eye. Okay, now I request Dr. Sandhya here. She will be talking about what are the difficulties a surgeon can expect when. Don't close this, huh? Can you just minimize it? Open it. Aru?
Thank you, sir, for this opportunity. Challenges of IOL power calculation in short and long eyes. So the most of the third generation formulas, they performed well for average axial length eyes. That is eyes with axial length between 22 to 24.5 millimeter. But the accuracy came down on either side of the spectrum, more so for short eyes. Now, what are the challenges in short eyes? Measurement errors and effective lens position prediction errors will have a major impact on short eyes because of the high-powered intraocular lens, and even minor changes in ELP can produce large changes in the postoperative refraction. And in short eyes, there is high probability of having a steep cornea and shallow anterior chamber, which can cause difficulty in IOL power calculation. And also the lens is relatively more proximal to the retina, So a 1 millimeter change in axial length can produce a 3.75 diopter change in the IOL power in eyes with less than 20 millimeters of axial length. But this is much larger compared to that of a myopic eye. And also the IOL may be more anterior in the eye than the estimated effective lens position, causing calculation of an overpowered lens and a myopic post-op surprise. And also, IOLs above 30 diopters are expected to be only within plus or minus 1 diopter of the labeled power, whereas those in less than 30 diopters are expected to be between plus or minus 0.5 diopters of the labeled power. So in short eyes, since this IOL labeling tolerance is more, so there is more likely that it may not be coinciding with the actual labeled IOL power. So coming to long eyes refers to eyes with more than 26 millimeters. So they have steep cornea, deep anterior chamber, thinner crystalline lens, and they may have posterior staphyloma. And all these will add to power calculation difficulties. And they have a large capsular bag. So the intraocular lens can sit anywhere within the lens. So we cannot predict the effective lens position because of the loose capsular bag. And the machine, the optical biometers uses a standard refractive index to calculate the axial length. In long eyes, the proportion of the vitreous body is large. So the contribution of the refractive index of the vitreous is more compared to that of that is what used for normal eyes. So they try to overestimate the axial length. So the IOL power will be falsely low. So they'll end up in a post-op hyperopic refractive surface. And also the long eyes may be associated with posterior staphyloma. This is uncommon in eyes with less than 26 millimeters of axial length, but around 60 to 70% of eyes with more than 33.5 millimeter axial length will have a posterior staphyloma. So if they have posterior staphyloma, then there will be difficulty in obtaining a distant retinal spikes in A-scan ultrasonography. And also, sometimes the ultrasonography the A-scan will measure the anatomical axial length, that is from the corneal vertex to the posterior pole, instead of the refractive vertex, that is refractive distance, that is from the corneal vertex to the center of the fovea, because you don't know whether the fovea is, there is no way to identify this fovea. And also we should suspect posterior staphyloma when you get abnormally long axial length measurement which are inconsistent. But we are fortunate that low power of the IOL will make the effect of IOL position less significant on the final refraction of the eye. So these are the difficulties that we encounter in short and long eyes.
Madam, anything you are changing in for minus lens when we are using that minus power lens? So any precaution you are taking for calculating IOL power?
It's in long eyes, you mean?
On long eyes with minus IOL power.
Long eyes, what I usually do is I take Barrett Universal 2 formula, and if I'm using third generation formula, I use the Bangkok modification. Not aware of any specific cell.
Can I? I think Dr. Sandhya has covered the points extremely well for the high myopia. I mean, the main problems is the biometry. Even if you're not doing optical biometry, then what IL formula Madhu was asking, and then what is the IL that you're going to select in these patients. Suppose to staphyloma, I mean, if you measure the anatomical axial length, you're going to measure the falsely long axial length. So that can be overcome by using the A scan, which is taken from the central vector axis of the B scan. So your A by B scan machine should be able to tell you where exactly is the fovea and then take the axial length measurement there. That is when you're doing a ultrasound biometry, immersion tag. And in that situation, if we're using the older generation formulas, you have the Bangkok optimization of the axial length for the optical biometry. So, I mean, these are the formulas which we have been using, and Recently, Madhu, there was an article that was published. Axial is more than 28 millimeter. They found that heel RBF and Kane formulas were more accurate in these situations. And as regards your query about the minus power lenses, the meniscus lenses. So any lens that goes below 5 diopters becomes a meniscus lens. Okay. So the A constant also changes for that particular lens. So if I use the heel RBF or Kane formula, Barrett Universal 2, with that IL constant, I think what the power that you get is quite okay. So I would not be selecting a zero target, but I zero refractive error target, but minus the first negative power that I get for these cases. Is this what you wanted to talk about?
Yes. Like we have to change the A constant, like what we are using
So
normally.
we don't have to do it that. See, these lenses which are exchange, they have a different already loaded in the incorporated in the
Yes.
biometer. If you click on that, automatically the constant changes. And if it doesn't change, then you'll have to. If your machine doesn't have that particular lens incorporated, loaded into its software, in that case you can just use the A constant out of the lens and then it gives you the power, right, Sanjay?
Because the lens becomes like a spherical, means convex to concave. So there will be some changes.
In IOL Master, when we click the drop box, all the lenses will come with the optimized A constant itself.
Yeah.
So we don't have to change the A constant in that.
That's what I was telling. So when you take the drop box, that lens you're going to use, that will be coming up. So you click on that, A constant automatically changes. But if it is a new lens that has come in the market, that is not there in the IOL Master or any machine, any other biometer, in that case you have to put in the A constant, right? Yeah.
Yes.
So now this was another study where a patient who has undergone a scleral buckle, in a high myopia patient. So I mean, do you really want to adjust the formula for these patients? It was shown that all the new formulas did pretty well, but Barrett Universal 2 and Harvard QST gave us a more hyperepic result. And with Holiday 1 and SFP formulas, which had already excellent optimization done, little myopic error. So many of these buccal dyes do extremely well for the rest of the life, isn't it, Dr. Meena? They have got 6 vision. So it is important for us to be aware of these factors and titrate the iron power or inform the patient that there is a likelihood of some error that may creep in. So this is about. Then again, if a patient has got a buckle done, then if the IL lens calculation is, let's say, more than 14 diopters, we reduce the IL power by 0.5 diopter. Anything less than 14 diopter, you don't have to alter the IL power. So this is about hyperopic eye, Dr. Sandha has already mentioned. And again, in this case, first choice will be, the Kane formula, Barrett Universal 2, Hill RBF, Hopper QS2. So these are the newer formulas which do pretty well. But, there is, short eyes is more tricky. Anything less than 20 millimeters is very tricky. So we take multiple formulas and then find out, which formula there's a particular value, there's concordance between how many formulas, and then you would like to select. Many of these patients are young patients, so they require a good, refractive correction in the post-op, good refractive status in the post-operative period, unaided status. So they're young patients, so we have to talk to the patient that there is a likelihood that we may off the target because of the anatomy of the eye. So a proper counseling has to be done. But these are the formulas which give very good results. So, Dr. Meena, can you talk about now? I would like to request Dr. Meena. Excuse me. Next slide. So I request Dr. Meena. See, another situation that we get very often is cataract surgery in vitreotomy eye. So many patients are diabetic. There's a lot of patients that are developing vitreous hemorrhage situations where vitrectomy has been done, silicone oil has been implanted, has been placed in the posterior segment. So we have to do cataract surgery for those situations. And in institute, the numbers of such cases are not insignificant. There's still good number of cases where you have to do cataract surgery. So I'd like to ask Dr. Meena to talk about, what are the precautions you take to make sure that you get proper axiometry, axial correction calculations properly done. And when you want to implant a lens, how do you select the lens power? Does silicone oil in the posterior segment have any effect on the IL power selection? And how to counsel these patients?
the best option in these patients whom you are planning a posterior segment surgery, be it a buckle or a complicated vitrectomy with silicone oil tamponade, is to do the A-scan biometry before you take up the patient for the posterior segment surgery. And you can archive it in your records. You may even give a copy of it to the patient so that if he's going elsewhere for his further surgical procedures, it can be used. If you're not able to do that, then it is best to do the IL power calculation using the optical biometer. But in certain situations, when you have a very dense cataract, or if you have a thick posterior subcapsular cataract, optical biometry may not be possible in these compromised eyes. And you have to resort to using an ultrasound biometer. So the challenges when using the ultrasound biometer is that there is an erroneously long axial length measurement, especially if the eye has a silicone oil tamponade. And sometimes in eyes with very dense macular edema, especially in patients who undergo phagovitrectomy and need for a macular pathology. In these patients, there is erroneously short axial length measurement if you're using an ultrasound biometer, because it measures only up to the internal limiting membrane and not up to the level of the retinal pigment epithelium. So when there is silicone oil in the eye, it slows down the speed of the ultrasound and there is apparent lengthening of the globe, and hence you erroneously measure a longer axial length. The speed of the ultrasound in silicone oil depends upon the viscosity of the silicone oil that you have implanted. And you are operating on a patient who has undergone surgery elsewhere. They usually do not specify the centistokes of silicone oil that has been used. But commonly in most of the centers, we use 1,000 centistokes silicone oil. And the ultrasound speed is around 980 meters per second compared to 1,532 meters per second in the normal vitreous. So there is that much slowing of ultrasound speed. Then again, when you're doing the scan, you see that the retinal echoes, which are supposed to be very highly reflective, become shorter echoes. There are poor retinal echoes. And if you're dealing with an eye which has emulsified silicone oil, there is multiple reduplication echoes in the baseline. All this makes correct calculation of the axial length quite difficult. So in this situation, it is necessary to convert the apparent axial length into the true axial length, making adjustments for the ultrasound speed in silicone oil. If you have an ultrasound biometer which is not very advanced and you cannot set the vitreous gate at a particular level, the velocity gate in the vitreous at a particular level, and there is a uniform velocity gate, what axial length you get is much larger than the true axial length. Then in this situation, depending upon the viscosity of the silicone oil that you're implanted in the eye, you can either convert into the true axial length by multiplying it with a conversion factor. For this, we need to know the type of oil that is in the eye. Or you can use this formula and convert it, and then this converted axial length is added on to the anterior chamber depth and the lens thickness to get the true axial length. But if you have an ultrasound biometer in which the velocity gates can be set, you can set the velocity gate to the type of silicone oil that is inside the eye, and you can get the true axial length measurement. Sometimes you have an incomplete silicone oil fill, and there is a retrosilicone space that between the bubble of the silicone oil and the surface of the retina, which is filled with posteriorly circulating aqueous. The space is maximum when the patient lies down in the supine position where we actually do the scan. So in this patient, it would be a good option to have the patient sitting up and do the scan, but this retrosilicone oil aqueous pooling is minimal. If you look at the refractive index of silicone oil, it is closer to that of the refractive index of the lens. And most of the lenses, the power of the lenses is located on the posterior aspect of the lens. So this adds up to a hyperopic shift in the diffraction, especially if you plan the cataract surgery and if you're not going to remove the silicone oil. The patient will have a transient hyperopic shift in the refraction, and it is your duty to counsel the patient. Counsel the patient and tell them that there will be a transient hyperopic shift, which disappears when subsequently you remove the silicone oil. This hyperopic shift is greatest with the biconvex lenses and least with the meniscus lenses. But there are some situations when you have a bad retina and you don't plan to remove the silicone oil from the eye. There are some cases in which we have to replace the silicone oil maybe once every 2 to 3 years. In these situations, it is necessary When you plan to maintain the silicone oil tamponade for an extended period of time, it is necessary to use a lens which is about 3 to 8 diopter more than the calculated power. And subsequently, if at any point down the line you remove the silicone oil, you have to explain to the patient that he is going to have a myopic shift in his refraction. So on these two aspects, you have to counsel your patients before you take them out for surgery. You can also use this following formula to find out the amount of additional power that is needed when the patient needs an extended period of silicone oil tamponade. The second situation is we are doing more and more of phaco-vitrectomies, especially for macular pathology, where the vitrectomy procedure per se is much simpler than for a complicated retinal detachment. In this situation, if you are using the ultrasound biometer, there is an erroneously shorter axial length that is measured. And in this situation, the eyes tend to have a myopic shift in refraction. So you use a lens which is about 0.50 diopter more, especially in eyes when you're doing a phaco-vitrectomy. There may be some situations where it's not possible to get the axial length and there is a damaged anterior segment. There's a lot of emulsified silicone oil in the eye. In this situation, you can opt for an intraoperative biometry after the cataract surgery, an intraoperative retinoscopy, and sometimes you use a CT scan to measure the axial length. We look at the formulas that are used to calculate the IOL power in these compromised eyes. All the newer generation formulas exhibit a better prediction accuracy compared to the traditional formulas. And if you're using a traditional formula, a highly myopic eye with an axial length of more than 26 millimeter, the Bangkok adjustment has to be used.
So I think we have about only 3.5 minutes left. So we will take some questions from the audience if there's any question in the mind, or if any of the panelists would like to contribute any points that have not been touched upon or request more clarification, please do it.
So I have one doubt. This Hofer Q, the new modified Hofer Q formula. So where is it used? Is it used in short eyes or
Short eyes, yeah.
short eyes? Okay. So anyway, original Hofer Q we can't use, no, because it doesn't take care of
because it has been upgraded to Hofer QST.
Because the original one doesn't incorporate even the anti-chamber depth, so that is obsolete now.
Hofer Q himself has, when I have heard him talk, say that people won't give it up. Though I keep telling that it is an obsolete formula. So he has modified it to offer QST. It is available in his own dedicated website for this formula. It's available in the ESRS IOL calculator. So it is very easy to access.
One question for madam, like when we are doing combined surgery for macular hole along with cataract surgery or ERM peeling with cataract surgery, so any change in IOL power we have to do, or we have to implant same power what we are getting from optical biometry?
Most of the patients with an epiretinal membrane usually have a thickening of the macula. If you are using an optical biometer to measure the axial length, you need not change anything. But if you are using an ultrasound biometer, then you have to actually measure the thickness of the macula by OCT, and that central retinal thickness has to be added to your axial length to get the actual axial length.
So many of these eyes, phaco-vitrectomy eyes, there's usually a myopic error, to the tune of 0.3 or 0.5 diopter. So one could also take that into account and implant a lens accordingly. But most of the time, until unless it is an ultrasonic biometry, we don't do it. There are a couple of other issues, like if we use gas with the posterior segment, there may be power variations in the postoperative period. Those are still unpredictable. We know it is happening, but how exactly to counter it precisely? What are the values of lens power adjustment? Not really that well clarified. Yeah.
Anup sir, thank you for the talk. I have a very small doubt. Post refractive surgeries, should you take the posterior corneal curvature into account? No, sorry. Do you want to take formulas which incorporate the posterior curvature into account, or can you just use the Haig's L formula?
Post-refractive surgery.
Post-refractive surgery, actually, we have got very nice formulas. The Barrett True K formula is there. And also we have got an ASCRS calculator, which uses 5 formulas and give an average of that. So Barrett-Truke, it is there in most of the like IOL Master 700 is there. If that is there, that is the best formula to use, and it is available online also. And then in post-refractive eyes, what is the problem is that we are altering only the anterior cornea, especially LASIK eyes, and not altering the posterior cornea. But most of the keratometry devices, they use a refractive index that assume a fixed ratio between the anterior and posterior cornea. So if you take the measured anterior cornea by keratometry and all, so the refractive index will be at fault because this is altered cornea. So that is one thing. And another thing is most of the manual keratometers, they'll take around the paracentral area. So, but the central part is the part that is flattened by the laser procedure. So it is not taking into account that. And another thing is that formula error is there. Because if you take the measured reading, then usually from the corneal curvature, we assume the anterior chamber depth. So here the measured reading is altered. But that is not the original reading of the patient. So the anterior chamber depth is not altered by LASIK procedure, but it is only the cornea that is altered. So if you take these, we have to take into account these things. And actually the Barrett-Truke, it incorporates all these things. So if you enter the measured things, it will automatically correct these things and will give you the value.
So I think, we'd have the discussion at the end of the session. So thank you so much. So in summary, IL power calculation is a very happening field. Every other day we get to some new information and need to be aware and what to be incorporated in our IL practice, in IL power formula calculation and to get better post-operative visual outcomes. And for that, we need to know what exactly is happening, what are the new things that are coming up, what can be adaptable. And I'm sure with these, precautions, with these activities, your IL calculation will definitely be better results. I would like to thank all the panelists for being there, and thank you very much.
Thank you, sir, for the opportunity.
Thank you, sir.